Welcome to Selecting the Right Intervention and Measures. This is part of the ICE training series, which already has included last year, 2014, an overview lecture that is still available that focused on setting the stage. This year, 2015, we will be producing 5 different short webinars, selecting the right problem, this particular module, selecting the right intervention and measures, selecting the right methodology, collecting and analyzing the right data, and writing and submitting the right abstract. If you went through the previous topic, selecting the right problem, the problem has been selected. But now what do? Now we must focus on ensuring that the problem is clearly defined, the intervention we're going to use has been selected, and that the measures must be selected. That's what we will focus on today. So to get started, let's think back to the problem you've selected. And presumably you have a well-defined rationale. It has substantial benefit, or we're avoiding substantial harm, both clinical and economic. It's important to patients, and or it's aligned with important health system goals. As part of the process, presumably, you have determined the stakeholders. In other words, the people who will benefit from success, and secured their participation for the subsequent steps. Now, there may be stakeholders that aren't going to be on the immediate team, but they're sort of on the extended team. They're the people you want to get buy-in. They're the people you may have to get approvals from, but they may not be actually on the team itself. So at this stage, you should be determining who are those stakeholders and whether they will be on the team or not, and whether you have secured their participation. Lacking a good, clear problem can inhibit solutions. I love this cartoon. Something's just not right. Our air is clean. Our water is pure. We all get plenty of exercise. Everything we eat is organic and free range, and yet nobody lives past 30. So even if the problem is that nobody lives past 30, how they've established the problem, the way they've defined the problem, the parameters, is off target. And that will lead them down the wrong path. So setting the right description is so important. Problem statements are more than just informative. They provide the foundation for your team's work and allow you to go back and make sure you're on track. We recommend that you use the PICO method for creating your problem statement, although there are other ways of doing it. The PICO statement will have 4 pieces in the problem statement. One is the population. What patients? Are they all patients, random patients coming to the ER? Are they ICU patients? Are they patients appearing in the primary care office? Are they patients in the PC office with abdominal pain? So what defines the population? Are they a certain gender? Are they a certain age group? Who's the population that you're trying to solve the problem for? 2, what are you going to do differently? That's the intervention. So the problem will include the intervention in the problem statement. Comparator is what is the current standard used to determine if an improvement occurs. So we'll be comparing the results from the intervention versus the results without the intervention. And then finally, the outcome. What is the measure that will gauge the effect of both the comparator and the intervention? So after we've created the problem statement, we're going to now select the intervention. For this, we've got to engage the team. So you've now brought the people who are going to be on the team to the table, and you've defined the gap with the current state. There's something not right about the current performance level of this problem. And in that team meeting, you want to determine what is the ideal state. I always like to tell people, don't focus too much on feasibility. If you focus on feasibility right up front, you may censor yourself or shortchange some really important ideas. So you really want to focus on desirability first. There'll be plenty of time for focusing on feasibility later. And then got to collect information about the problem. And we understand what is causing the variation in the current performance and what's causing the problem? So what do we look at for that? Well, it may be something as simple as anecdotes that we've heard. That's not very robust, but maybe that's where it starts. It may involve counting defects or counting harms or unintended events. Usually at some point in the process, there will be some flow charting or process mapping to try to make sure you're considering all aspects of the process that's being looked at. Even more formally, you'll get it to root cause analysis or failure modes effect analysis. Either one of these very rigorous tools can be very informative in trying to decide what you need to do to create an improvement. Once we understand what are the various causes and modalities, we've got to create a framework that sort of links the causes to the results and demonstrates the interrelationship. Because when we're choosing interventions, we need to choose an intervention that will focus on the causal factor, knowing that there's a linkage between the causal factor, the intervention, and the results. Without understanding the causal factors, the results, and the interrelationships of the two of them, plus the interrelationship with the interventions you're being considered, it will be likely that you will end up with an experimental process that will be lacking. We shouldn't reinvent the wheel. We have lots of resources to understand what others have tried. Now you can do a search the literature. Just Googling for the problem will potentially, and maybe adding the words quality improvement, will bring you other sources of what people have tried. You might find gray literature such as abstracts or poster sessions. You might find topics that have been listed in various conference programs where you can go back and contact the author. You can also look on listservs and often do a Google like search on a listserv. And then, of course, you can consult your colleagues in your network. It could be your organizations, the entire organization, or just people you tend to work with. From all of this, you can determine a list of possible interventions. Typically, there'll be more than one thing you can try. And then you're going to want to select the intervention you're going to try, and you need to develop a rationale for that. Now, in rigorous experimentation and research, you typically will only change one thing at a time. In the real world of patient care and quality improvement, it may be necessary to try 2 or 3 things at the same time. There will be consequences to that. If you find out that you're very successful, you may have 2 interventions. Let's say you tried 3 things all at once. And you may find at the end you have a very successful project, but you don't know if all 3 of them are necessary or maybe only one of them is necessary. Well, that can be further experimentation later on. But try to include enough things so you feel pretty confident that you're going to have a successful effort is really important. With each intervention, there could be, of course, unintended consequences too, and so including more interventions can increase some risk in some ways. After you've selected the intervention, you're going to have to select the measures that you're going to use that are going to lead to buy-in for the project. The right measures are really key because if you're going to use this to convince other people that they should approve a new process, that may involve extra resources in your area, or it may involve changing the workflow with someone else, or changing someone else's scope. You're going to need that buy-in. And to get that buy-in, you're going to need the right data. You've got to make sure that your measures are involve causation. And hopefully, if you've done your framework up front correctly, you know what's causal and what's just a correlation. We always have to be careful about things that tend to move in the same direction in our experiments, but they really aren't causative factors. And the other thing we have to consider is both benefits and harms. So yes, your intervention may lead to some benefits, but it can also lead to harms. And if you're not watching for those harms, when you're trying to sell the value of your project and someone asks you, well, did you think about this? That was a negative and you didn't do that, your whole initiative will be weakened for that. So it might be that you can cut testing but increase length of stay. Well, cutting the testing, if you're looking for a reason to cut testing, that may to you be a sufficient outcome. But if you'd missed the fact that you've now increased the length of stay or increased the cost of imaging tests inappropriately, and now there's more imaging tests going on, or other things like that, again, it will weaken the overall outcome. When you think of measures, we typically think of three types. There are the structural measures that are a feature of a healthcare organization or a clinician related to the capacity to provide high-quality healthcare. It's the provision of IT services. It's the number of beds you have. It's the size of the emergency room and the tools in the emergency room. From a process perspective, we're thinking about outcomes related to or measures related to a healthcare-related activity performed for or on behalf of or by a patient. So now we're talking about an activity, not just the structure. And then finally, the outcomes are the health state of a patient resulting from healthcare. For ICE, we really care about that last category most. There are many calls for abstracts about show us what you've done to improve the efficiency of your laboratory. Show us how you've saved money. Show us how you've reduced labor. And those things are valuable. And even in CLMA, there are calls for abstracts that will demonstrate that. But ICE is different in that we require the linkage between the initiative and patient outcome measures. The reason for that was presented previously, so we're not going to go into that again here, but I would encourage you to review the 2014 overview if you want to know more about the rationale behind the ICE initiative. Now, patient outcome measures relative to laboratory are really quite challenging. As you can imagine, there are lots of things that go on in a patient outcome besides what the laboratory is doing. Physicians have to retrieve results, they have to interpret the results, they have to act upon the results, and other things are going on at the same time. So to say that this laboratory activity produced this patient outcome can be challenged. Doesn't mean it's impossible, but it can be challenging. And the outcomes themselves can be influenced by many factors besides just what we control. So you introduce a new LIS system, there's an upgrade, or you introduce someone else is doing a quality improvement initiative that affects the same set of patients. So that will create methodological issues. If you're doing a pre-post analysis, you do an intervention and you compare after the intervention to before the intervention, there are many different things that could have changed in those time periods. So we have to think about how we have the strongest linkage to patient outcome measures. And then if you are using multiple interventions, as we mentioned earlier, you may not be able to determine their impact individually. So let's talk about a couple different ICE outcome measures, or how we think about outcome measures. So first thing, a direct measure of patient outcome might be things like time to diagnosis, morbidity or mortality, patient satisfaction. But also can be things like reduced seizures, and I mention that specifically because of something you'll see later on this slide. And fewer adverse events, such as sepsis. And again, I'll give you an example with that later. A strong linkage may not actually tell us the state of the patient, but we know that having increased transfusions puts the patient at substantial risk of other kinds of secondary infections or other kinds of problems. Using antibiotics unnecessarily can create gastrointestinal side effects and more resistant, antibacterial resistant bacteria, and it can reduce readmissions. So these all have strong links, but they are not the health state themselves. Even length of stay isn't necessarily a direct patient outcome, although it's certainly a very strong linkage. It just doesn't it depends on the reason for the length of stay increase. A moderate linkage might be things like time out of therapeutic range. So if you're dealing with an anticonvulsant and you measure the time out of therapeutic range, that's one thing. But going back up to the direct measure, if you've reduced the actual number of people presenting with seizures in your emergency room, and you look at whether they were in or out of therapeutic range at the time they presented, and you can have an intervention that will try to change your target population, you can see the difference of reducing seizures versus reducing the number of people or the time out of therapeutic range. Reduced rate of recollects, yeah, it adds 10 or 15 minutes maybe to a patient, maybe even a half an hour. It may cause them to come in, but in the course of a disease or process, it may be more of a moderate linkage than really changing their health state. And finally, weak linkage. We may think of hemolysis as really something we want to reduce the number of defects on. It does create an efficiency issue, but it doesn't necessarily, it can't prove that it's going to change the health state of the patient. Same with short fill rates. Unless we have the data on patient impact, we don't necessarily know that we've got a strong linkage there. As we come to the close of this little overview, and again, this was not intended to tell you the how-to details of each of these steps, but provide an overview. And on our website, we do provide more resources for more information. But there is important to think about what are the risks at this stage of the process when we're just doing the interventions and measures and thinking about them. Well, one, maybe the problem statement doesn't adequately define the scope, and so we don't have that foundation to go back to see if we're staying on track. Maybe the team is too narrow, and if the team is too narrow, you're missing some expertise that you really need. Unintended consequences are not considered. You can, again, reduce the use of antibiotics, but maybe increase the length of stay. So if you weren't looking for a change in length of stay, then you may have introduced a risk into the project. Budget, resources, impact. If you haven't really thought up front about what are you going to need to conduct this research, this quality improvement project, and whether you've got the approval, if you haven't confirmed that support, you could be halfway down the path when you run into a problem, and that may cause you to have to stop or start again or something like that. So with any intervention, with any project, before you start it, you really need to make sure you have a strong plan in place, whether you're using methods like PBSA or others to reduce the risk. It's important to have a method to reduce the risk of project stoppage and or review. Let me just take you through one quick ICE submission from last year. Rebecca Burke from Central Ohio Primary Care, a physician office lab, submitted this, and it was a very high-scoring submission. And just to real quickly see how she did it, the patient population were all the patients scheduled at this urology group for prostate biopsy. The intervention was to do a pretest for fluoroquinolone-resistant E. coli, and then if they had present in their flora that bacteria, then they had a different prophylactic treatment than if it wasn't present. So they changed the prophylactic treatment depending on the results of this test. The comparator was the sepsis rate before they did this, and the outcome was the sepsis rate after the intervention. So these are very definitely about the health state of a patient. We're not going to talk about the results except to say that when they did this intervention, they had a very nice reduction in sepsis rate. So you can imagine why it was high scoring. That's the kind of thing that will help you go back and continually recheck whether you're on track with your project. So in summary, a well-written problem statement increases the likelihood of success. Candidate interventions can emerge from literature, from colleagues, or from the project team. But an independent investigation is critical to understanding of the problem. This means doing the FMEA or the root cause analysis, something to make sure you understand the causation factors and how they're interrelated. That is really critical. And then when you select measures, you really need to select measures that are going to detect the effect of the intervention as well as other unintended benefits or harms. So you can't just select an intervention or a measure that focuses only on the good aspects of the intervention, because that leaves yourself open to challenges later on from other stakeholders. So with that, let me bring this to a close and say good luck with your ICE initiative, and we hope to see your submissions as you proceed through the process. Thank you.